Going to the pathophysiology, as we mentioned, it's mainly because of hemoglobin S polymerization. When hemoglobin S polymerizes under deoxygenated state, this will change the shape and the physical properties of the erythrocyte, which will result in two problems: hemolytic anemia and blockage of the blood flow, especially in the small and sometimes in the large vessels. This sickling happens, as we mentioned, at low VO2 levels, and it depends on how much hemoglobin S is present in this patient in this time. And it's aggravated by acidemia, increased CO2, increased 2,3 dBg, fever, and increased osmolality. Which organs can be affected? Any organ. Let's see some examples in this very good illustration, also from the same Nature article. In green, a chronic complication; in yellow, the acute complications. Let's take any organ, for example. Heart, it might have cardiomegaly or diastolic heart failure because of the chronic anemia. Bones, they might have a vascular necrosis as a chronic complication, or bone marrow infarction or osteomyelitis as an acute complication. Even pregnancies can be complicated. Eyes might have complications, and so on and so on. This another table will show you just how any organ can be affected, and this will give you a different presentation of the disease. If we will go to investigations, because of it's a huge burden, and the idea of today's medicine is preventive medicine is very, very important. So that's why we should talk about screening as well as diagnosis when it comes to investigation. Thankfully, premarital, antenatal, and neonatal screening programs have been established in some high-income countries, including parts of the Middle East, including Saudi Arabia and the United States. But more importantly, such programs are starting to be developed in areas with very high prevalence of sickle cell disease like Africa and India. Here's a snapshot of MOH website, which will show you that sickle cell disease in Arabic, فقر الدم المنجلي, is part of the premarital screening, which is mandatory. Screening test, there are more than one type of screening test. One of the commonly used tests is the solubility test, and if it's positive, as you can see here, because hemoglobin S is less soluble, it will tell you that they have hemoglobin S allele, but it doesn't distinguish hemoglobin SS from hemoglobin AS. To do that, you'll have to get hemoglobin electrophoresis. As you can see here, this is a normal hemoglobin A in a normal adult. This is a combination of hemoglobin A and fetal hemoglobin in a normal newborn. Here's a sickle cell trait where they will have hemoglobin A and hemoglobin S combined. They will not have the clinical manifestation of the sickle cell disease. And here's a sickle cell anemia patient. They will have basically hemoglobin S. Then if they have SC, they will have S and hemoglobin C combined. If we go to management, patient with sickle cell disease needs a multidisciplinary comprehensive clinic where they not only address their symptoms and its management, but they also need patient and family education, empowerment. However, in reality, such centers are rarely available, even in developed countries. Long-term management starts with establishing the diagnosis, as we mentioned, then genetic counseling, premarital counseling, trying to prevent this disease even from happening. Then if the disease is there in any subtype, management will be centered on preventing crisis. How we can do that? It's by avoiding conditions that promote sickling. So try to avoid hypoxia, avoid and treat acidosis, avoid dehydration, avoid and treat fever. This will also include vaccination in childhood, especially against pneumococcus, meningococcus, and Haemophilus influenza B. Also will include prophylactic antibiotics. And as any other chronic disease, they will need to have good hygiene, good nutrition, and good social support. So we cannot talk about long-term management without mentioning hydroxyurea. Hydroxyurea made a huge difference in the quality of life of sickle cell disease patients. Once it was observed that fetal hemoglobin will ameliorate the sickle cell disease severity, pharmacological drivers of this hemoglobin F fetal hemoglobin have been sought. So how does hydroxyurea work? It induces hemoglobin F by recruiting a population of erythroid precursors that can continue gamma chain synthesis into adulthood, which are otherwise remain quiescent in the marrow. Then, as you can see here in the bone marrow before therapy and during therapy, they will have reduced cellularity, increased proportion of the nucleated red cell, which produce hemoglobin F. The blood will have increased hemoglobin F, macrocytosis, which can be monitored as a clue that the patient is compliant to the medication, and as also an important measure to reach the appropriate dose for this patient. Also, it will show increased hydration of the cells, fewer sickle cells, fewer reticulocyte, and fewer granulocyte. This is a blood vessels. Before therapy, it will have much more sickles and sickled clots. During therapy, it will have improved flow. So, the multicentered study of hydroxyurea was the main randomized trial that showed how hydroxyurea will reduce the vaso-occlusive events by nearly 50%, and that it will increase the total hemoglobin and fetal hemoglobin, which will also reduce the incidence of acute chest syndrome. It will reduce the transfusion dependency, and by all of that, it will reduce mortality. Other studies showed that it's safe for long-term use, which finally led to FDA approval in 2017 for hydroxyurea even in children 2 years or older. Then if we talk about long-term management, also we have to talk about how we will screen for complications. We saw how it might affect any organ, so we have to be very vigilant by doing regular blood works, urine analysis, transcranial Dopplers in children and adolescents, retinal exam, and even echo. In this table, you will see a summary of the recommended treatment, which is the standard of care for sickle cell disease currently. And this was published in a New England Journal of Medicine in 2017. You will see the doses of hydroxyurea. You will see when these patients will need blood transfusion and what type of infection prevention they need. If you see this table, it's a promising table. It shows you the trials that are going on for emerging treatment for sickle cell disease. The huge number of trials reflects that this disease is really not silent. Like, you see the patients suffering, screaming of pain in the ERs, and then having to deal with all of the complications, surgeries, and so on. So this promotes researchers to find a better solution and something to improve their quality of life. And one of the a new modality of treatment is hematopoietic stem cell transplant, which is potentially curative, but its use is restricted by its high cost, toxicity, and limited availability of donors. But with time, it's becoming more applicable with the development of less toxic conditioning regimens and the use of alternative sources of donor cells. So by that, we finish the long-term management, sort of. Now we will go back to our patient in ER. This is the patient who presented with vaso-occlusive crisis, screaming of pain. So what's a vaso-occlusive crisis? It's basically an ischemia reperfusion injury, and it might affect any organ. They'll present with severe pain, with fever and leukocytosis. It might even cause a stroke or a silent MI. It's usually precipitated by infections, dehydration, change in temperature, pregnancy, menses, or alcohol. If you see one patient with vaso-occlusive crisis, the next patient will be very easily to diagnose. It's a clinical diagnosis, no specific test. You have to trust that your patient's pain is real. It has a pathophysiology behind it. And the tests that you do are to rule out other causes of his pain or other complications. So you'll have to do a CBC, renal function, liver function, to see if anything is affected, hemolysis indices to see the severity of the hemolysis, hemoglobin electrophoresis, to see the current hemoglobin S and hemoglobin A concentration, septic workup depending on the symptoms, and either chest X-ray or imaging of the affected organ. You have to start treating their acute pain while evaluating for the causes. To start the analgesia within 30 minutes as per American Society of Hematology ASH guideline, or within 60 minutes of registration. You have to base your analgesics selection based on pain assessment, serious symptoms, outpatient analgesic use, the patient knowledge of the effective agents and doses, and their past experiences with side effects. So you trust them, you ask them. For mild to moderate pain and in patients who have been responding before to non-steroidals with no contraindication, you can continue treatment with non-steroidal. If they have severe pain, you'll have to use parenteral opioids, and you'll follow the local guideline of that. You have to also use non-pharmacological approaches to treat pain as an adjunct, like heat application, distraction, and so on. And to reduce the risk of acute chest syndrome, which is an emergency, basically a chest infection plus or minus infarction, you have to encourage the use of incentive spirometry while awake. So as much as they can, they will use this device. It's easy to use. They just need to blow through it, and respiratory therapy can educate the patient on how to use it. Also, you have to encourage ambulation as soon as possible. Blood transfusion is not usually needed. If you have another indication for blood transfusion, you will transfuse them. But they might need hydration, because usually they're unable to drink fluid because of the pain. And we mentioned that dehydration is like an aggravating factor for sickling. So give them IV fluid, but don't overhydrate them. You just need to give them their maintenance rate. And if they're having low oxygen, which is like less than 95 on room air, you have to give them supplemental oxygen. This sums up how to manage a vaso-occlusive crisis, which is one of the main and most common complications of sickle cell disease. Also important complication, you can go through ASH bucket guideline. In this list of references, you will find very helpful articles. The ASH bucket guidelines and these 3 articles, they will give you more in-depth information of whatever we discussed today, and they are easy to read, inshallah.